All rise. Court is now in session. You may be seated.
All right, counsel, plaintiff's next witness, please.
Yes, Your Honor.
Your Honor, at this time, plaintiff calls Dr. Stephen Jose.
Doctor, would you please step into the witness box and raise your right hand so that you can be sworn?
Stephen, S-T-E-P-H-E-N, Jose, H-O-S-E-A.
Oh, yeah. Good afternoon, ladies and gentlemen. Good afternoon, doctor. How are you?
Really good, thank you.
Good. You mentioned your name. Would you tell ladies and gentlemen of the jury your profession?
I'm a physician.
And what type of medicine do you practice, doctor?
I'm a specialist in infectious diseases, which means I see people who acquire various kinds of infections. They can be bacterial infections like pneumonia, it can be meningitis, it can be cellulitis. I see people with viral infections like influenza and HIV disease, and all different kinds of infections. Anything you can pick up from someplace else that would be considered an infectious disease.
All right. And when a person practices medicine in the area of infectious disease, what do you do? I mean, because I before I started practicing law and trying these types of cases, I didn't know that I could even go see an infectious disease doctor.
Usually people come to see me because they've been referred by another physician who has seen them and deemed them to have some sort of infection. How do people know that they have an infection? Usually they have fever, chills, elevated white count, or they may have some blood tests done that would suggest that they have got a condition that is consistent with an infectious disease. If you go on a trip to Southeast Asia and you come back with bad diarrhea, you've probably picked up a bug from Southeast Asia, so somebody would see me in that situation.
Okay. And besides infectious diseases, is there another area of medicine that you also specialize in?
Well, I also teach internal medicine to the interns and residents at Santa Barbara Cottage Hospital. It's part of the internal medicine training program, and I've been doing that for approximately 28 years. I see their patients with them. I'm the attending physician for them, and then every day I meet with them at least 2 to 3 times a day and go over their patients and really teach them, basically shepherd them from being medical students to being doctors.
All right. And what type of areas, internal medicine, what types of patients do you see or would you see? What does that area of medicine focus on?
That area of medicine is essentially general internal medicine, and because most people who don't have insurance, disenfranchised, problems with alcohol or whatnot, they don't have physicians, those are the folks that end up on the residency service, and I end up caring for, helping them care for. Again, primarily because they don't have primary physicians of their own to take care of them, so we do that as part of the residency program.
All right. So that's the type of medicine that you practice, and you're here today because you were retained by my firm to work on this case.
That's correct.
You're a retained expert as opposed to someone who's already working in the case because they were treating the patient.
That's correct.
We have retained experts for the plaintiff. Defense has retained experts for them. Tell the jury just a little bit, why do you work as a retained expert? What are you doing this for? Tell us about that.
All right. Maybe interrupt, you can stop quickly. I would ask the counsel just to ask questions.
I can do that.
Okay, go ahead.
Could you tell us about your work as a retained expert?
Yes. I began back in the mid-1980s primarily doing defense work because attorneys would come to me and ask if I would help in various medical legal cases. And as I started to do medical legal work, it made me a better physician because if I can understand why things occur, why decisions are made, not only does it make me better, but I can teach that better to my interns and residents as well. It also, in all honesty, supplements my income because a lot of what I do is take care of people who don't have any insurance or any finances, and therefore I use this to allow me to do what I do primarily.
All right. And do you work for both the plaintiff and the defense? Not in this case, obviously, but in other cases that you've worked on for the past many years.
Yes, I do.
All right. And you've looked at a number of records, medical records, charts, some of the jail records, statements from jail personnel, investigation documents, and those types of things early on, and there's more, but you reviewed a set of documents containing information about this case
That's correct.
and arrived at opinions and sent me an opinion letter, which we have filed and given to defense counsel. You're aware of that?
Yes.
And are you able to tell the jury today about your opinions that relate to the issues in this case? What Mr. Bruner contracted, how it affected him, how it overtook him, how it led to his death, if he could have been treated, those types of things.
That's correct.
Okay, now, juries have to assess weight and credibility to witnesses in every instance, so they need to know a little bit about your background. I don't want to belabor the point, and we'll have your CV, but just could you tell them, for instance, where did you go to undergraduate school?
I went to Harvard College.
All right, we've all mostly heard of that. Where did you go to medical school?
I went to Harvard Medical School.
All right, when did you graduate from Harvard Medical School?
1973.
All right. And when you were done with medical school, did that complete your education portion of your background?
Not really, because I went on and did an internship and residency at Massachusetts General Hospital, and then after I finished that, I went to the National Institutes of Health, and that's where I began to study infectious diseases. And then I spent another year doing clinical infectious diseases at Yale New Haven Hospital, and that essentially completed all of my formal training.
Okay, so the residency that you talked about, and then you went on and did additional work at the clinical research facility?
That's correct.
All right, and then you did what work at the Yale?
Yale New Haven Hospital, I did clinical infectious diseases. At the NIH, we take care of really esoteric, unusual sorts of things that you'd never see as a general infectious disease doctor. So I went and spent a year at Yale New Haven Hospital to see more of the general routine kinds of things that people see rather than just the exotic or esoteric kinds of things.
All right. And did you obtain what we call board certification, or what actually the boards of the various specialties in medicine call board certification?
Yes, I received the board certification in internal medicine in 1976 and in infectious diseases in 1980.
All right. And again, briefly, could you just walk the jury through just your employment and what you've been doing? So if it's important to them, they can say, well, we know that about this gentleman before he tells us.
Sure. After I finished the year at Yale New Haven Hospital, I was on the staff at the National Institutes of Health in the Institute of Allergy and Infectious Diseases and had my own laboratory there. I worked there for about 2 years, and I decided that I enjoyed taking care of people more than I enjoyed taking care of mice and rats and guinea pigs in the laboratory. So I left the NIH and I went to Santa Barbara, and that's where I started doing infectious diseases, clinical infectious diseases, and that was in 1981, essentially at the outset of the AIDS epidemic. So I spent the next several years doing a lot of AIDS medicine, and I also became involved with the teaching program. So that's when, and I've been doing the teaching program for 28 years and routine infectious diseases for about, I guess it's 31 years now.
All right. Thank you very much. In all that training and your background, do you know well, and do you work in the area of medicine that mainly deals with pneumonia, sepsis, meningitis, among many other diseases?
That's correct.
All right. And in this case, in addition to this report that you gave us, after you reviewed those initial documents and things, you were sent depositions and other things subsequent to your report, and even deposition. Is that right?
That's correct.
Does any of that information that you've learned change any of your opinions?
No.
Okay. Does it support your opinions?
Yes.
All right. Let's talk about that. What was the infectious disease process that befell Mr. Bruner? In your opinion, tell the ladies and gentlemen of the jury.
And the infectious disease process was pneumococcal meningitis. Meningitis is an infectious process that involves the coverings of the brain. Everyone is potentially at risk for getting meningitis. It's unusual for people to get it. It's commonly associated with having pneumonia because the same organism that causes meningitis can also cause pneumonia. When people get the pneumonia in their lungs, it sometimes can spread to the central nervous system and also cause meningitis. It's much more serious when you have meningitis because people die very quickly of meningitis. People can die of pneumonia also, but again, we have antibiotics now, which certainly has it effectively treats both those conditions. The key with any infectious disease is the sooner you treat it, the better off people are.
All right. Now, how does a person catch? Is the start of this then pneumonia
Yes.
for Mr. Bruner?
Yes.
And how do you have an opinion as to how he caught it, or how this begins for him?
Well, we know that people get pneumonia from other people. If somebody, or let's say, for example, if I sneezed right now, anybody who's within about 30 feet of where that sneeze would come from would be potentially exposed to pneumococci if I have that in the back of my throat. You would be asymptomatic from that. It wouldn't cause any problems if you had immunity to it or if you'd received the vaccine. But if you didn't have any immunity, then it could get down in your lungs and start causing pneumonia to occur.
All right. Now, I want you to assume that on the 5th of March in 2008, we've heard from a number of people who said that Mr. Bruner was sweaty, that he was sick-looking, looked ill or lethargic, was not eating. Is that consistent with, or do you have an opinion about what is that the start of, or is Mr. Bruner in a state of ill health at that point? What is it?
Okay.
I'm going to continue with that last question, but I'm going to change it. So I'll withdraw it and make it a little bit more clear, because I just want to make sure you understand it. Based upon the signs that I described for you as coming from other witnesses, do you recall those?
Yes.
Okay. And you recall I was talking about the 5th of March?
Yes.
Okay. As an infectious disease specialist, do you have an opinion as to what disease process was affecting Mr. Bruner at that time?
Pneumonia.
Okay. If pneumonia is affecting him at least as of March 5th, 2008, and it's left untreated, does pneumonia continue to exist in his body until he dies?
Yes.
And what's going on thereafter? Tell the jury about this process of pneumonia. First of all, can it be treated?
Yes, it definitely can be treated.
Can it be easily treated?
Yes.
Okay. How can it be treated?
How could it have been treated?
Yes.
Oral antibiotics. His organism was exquisitely sensitive to penicillin and every other antibiotic that was tested, so anything that was in most medicine cabinets, it's an antibiotic, would have treated this.
Okay. When you say exquisitely sensitive to antibiotics, what do you mean by that?
That means that just about any antibiotic that you would have chosen would have worked against the pneumococcus, that's the bacteria that was causing his pneumonia. We're in the times where there are some bacteria becoming very resistant to antibiotics, and therefore you have to choose a very special one. But pneumococcus, his pneumococcus in particular, was very sensitive to just about anything that could have been chosen to treat him with.
So it could have been easily treated with just about any of those antibiotics that you mentioned.
That's correct.
And are these common in clinics, hospitals?
That's correct.
All right. And if he's having symptoms, like I described on March 5th, the sweating, the lethargy, the looking weak or ill, if he's having those things, do you have an opinion as to whether or not those types of symptoms will continue?
Yes.
What was the first date?
The first thing, Your Honor?
No, the first date you said.
March 5th.
March 5th. I think this is squarely within the scope of the opinion stated in his report. Go ahead.
Thank you, Your Honor. And what's going to happen with those? I mean, does someone, there's been talk of maybe the person suddenly got better and looked like, instead of having pneumonia or something, he just looks like he has a cold. In medicine, does that happen, doctor, without treatment in the interim?
Usually not, no. Pneumococcal pneumonia, it's one of the more common causes of pneumonia, and it used to be the most common cause of killing people who had infectious diseases before we had antibiotics. But what happens is once the infection gets going in the lung, the body attempts to control that infection by the immune system. And what does that feel like? Well, when your immune system is active, you lose your appetite, you don't have much in the way of energy, sometimes people get confused, they cough, they're very lethargic, and that's all part of the immune system trying to fight off the infection which is there.
All right, doctor. And there's also going to be, there's been evidence in this case, there'll be more, and there'll be testimony about the cirrhosis issue. This is liver disease, right?
That's correct.
And again, I've already, I think, explained how well-versed you are in pneumonia and sepsis and meningitis, but how about liver disease? Is this something that you also have studied greatly and know much about and can give medical opinions to this jury about?
Yes.
All right. And this is a person who has liver disease. If we're talking about the 5th and the 6th and he has pneumonia going on in his body, but he's got liver disease also. So that's going to affect his immune system, right?
That's correct.
Can you still treat and save that person with antibiotics like you just described a little while ago?
Yes, most definitely.
Okay. Could you explain why, in case someone tries to suggest differently?
Sure. He had hepatitis C and alcoholism, and the combination of those two in particularly caused a lot of scar tissue to be present in the liver. And when you have scar tissue in the liver, it doesn't function normally. Normally what our liver does, it takes the toxins out of our body and it makes new proteins for us that go there from the gastrointestinal tract. When the liver is not working well, those toxins build up, and one of the toxins that builds up is ammonia, not pneumonia, but ammonia. It's NH4, and that toxin can cause people to be lethargic, not particularly clear. It can even cause them to be comatose at some times. There are various stages of liver disease because, as with anything, there's a beginning and an end, and there's a lot in between. And his liver clearly was not working very well. We have a way of calculating how bad his liver is because we use this calculation to determine whether or not somebody is a candidate for a liver transplant, because that's the only thing you can really do when people's livers stop working. And his calculations, his MELD score is what it called, suggested that he was going to die of his liver disease. He only had about a 6% chance of dying in the next 3 months of his liver disease where it was. We don't think about transplanting people until they're up to around an 80 to 90% chance of not making it in the 3 months. So he did have liver disease, but it was relatively mild in the full spectrum of what can happen to people who have damage to the liver.
Okay, so considering that score and that mild case of the liver disease, then let's talk about Mr. Bruner and giving him antibiotics. As you explained to the jury how those antibiotics are certainly going to work on the 5th or 6th or at some point during his process of suffering from pneumonia.
Sure. You give the antibiotics, they're absorbed into the bloodstream, they're taken to where the infection is, and the bacteria stop multiplying and dividing, and then your immune system can come in and clean up everything from there.
All right. Now, let's move forward a little bit further towards the 10th and talk about the 9th and 10th together. What happens to the process of pneumonia in Mr. Bruner, in your opinion, as we get to the 9th and 10th? Is it worse? Is it much worse? Is it how can you describe how badly he needs medical attention at that point? On the characteristics of the 9th and the 10th, which are most relevant, is that his thinking ability is way off. He comes out of his cell wearing his long johns. I must say that's something that I occasionally have a dream about, having not put my pants on when I go to work in the morning, but fortunately it's never happened. But it not only happened once to him, it happened twice, because the guard told him to go back in the cell and he still had his long johns on. So something was wrong with his ability to think. He was described as being dazed. He was moving very slowly. So something was affecting the functioning of his brain. Same thing happened again on Tuesday morning when he came out of his cell, and he was wandering around in a daze, moving slowly. Are you talking about the 10th, just so the jury's clear?
Yes.
Because I don't think we've broken it down for them in terms of Monday, Tuesday, Wednesday, but the 10th is the second day you're talking about?
Correct.
Okay. I didn't mean to interrupt. You can continue.
Okay.
Anything else?
About the 9th or the 10th?
The 10th.
Only, again, that when he was sent back to his cell, the door was unlocked and he kept closing it. He kept closing it. So he was doing repetitive actions that clearly showed that his brain was not functioning normally. And in my estimation, that was him telling everybody who was paying attention that something was wrong with him at that time.
All right. Now, in the initial reports that you got from the investigative documents and the statements from the officers and things, you didn't get a lot of the symptoms and things were brought forth by some of the witnesses here in this trial. But I'd like to ask you about them, just in terms of what's going on. He was described, again, as weak.
Interrupt, Your Honor. As he acknowledges, it's not part of the report, it's not part of the fees, not the property disposal.
Your Honor, I'm not asking him for his opinion based upon any symptoms, and I'm not asking him for symptoms. I'm just asking him if this is consistent with the disease process that he's described, so that I can ask him if the person can still be saved, as is written and described in his report in paragraph 6.
Respectfully, I think that's double. He's asking for an opinion as to whether or not the symptoms on matters that were not considered, were not disclosed, are now what is true or not. And it's well beyond the first orders of the court, Your Honor.
I'm not following the distinction that you're trying to make, so maybe if you want to ask the question a different way.
Certainly, Your Honor. Doctor, we are now, I'll withdraw the question and try to do this a different way. We are now, when we're talking about the 9th and the 10th, we're now talking about 4 and 5 days after your opinion is he has pneumonia ongoing.
Correct.
And we know from the record there's no treatment in the interim. He's not been given any antibiotics. And he's not even taking in any food or liquid, at least as far as we can tell, appreciably.
That's correct.
Without telling me the symptoms, would you expect significant symptoms to be apparent?
Yes.
Dramatic, much more so than on the 5th?
Yes.
Okay. And why? Is that part of the disease process as it continues?
Yes, it is.
Okay. So this is normally what medicine expects to see, someone really sick by this time.
That's correct.
Now, let's talk a little bit about sepsis. In your opinion, does sepsis occur before the meningitis sometime on the 10th?
Yes.
Okay. What is significantly different about sepsis, so the jury understands if that is that a big step in this process towards this man's death?
Yes, it is.
Okay, could you tell the jury why that's a big step?
Well, sepsis is when the whole body is now beginning to respond to a local infection. For example, if you have pneumonia, people cough, people bring up sputum. If you have sepsis, you can have a high fever, you can have a high white count, your pulse rate goes really fast, you're breathing really fast. And that means that the body is intensifying the response to whatever the underlying infectious process is. Oftentimes when sepsis occurs, that means the bacteria has broken out of where it is and into the bloodstream. And when it's in the bloodstream, then it can go anywhere else it wants to. It can go to the fluid in the abdomen, it can go to the brain, it can go anywhere at once, and the body is again more on alert to try and fight this process, which is a lethal process if it's not treated quickly.
All right, if a patient looks pretty bad with pneumonia after a few days of untreated progression and without nutrition or liquids of any appreciable amount, and then the person's overcome by sepsis, how much worse do they look when that occurs?
It's...
No, maybe I don't understand the parameters of this. The report doesn't mention sepsis. I think we're getting in things that aren't properly disclosed. That really aren't things that I anticipated this witness talking about, and I object.
Your Honor, the witness has already explained that the topic of pneumococcal meningitis necessarily includes both pneumonia and sepsis as the progression to get to the meningitis, which is the final step that we're about to talk about. This person didn't just have, out of the blue, pneumococcal meningitis. And so we're just talking about the precursor to the meningitis, which we're about to talk about as soon as we're done with this point, which is going to take about 5 minutes.
Go ahead.
So how much, You talked about how it's spread throughout the body. How much worse is this person off in terms of what you believe would be existing in the patient?
Well, again, how much worse can things get? People can't stand up, they can't walk. Their level of communication is even worse than it was. Previously, he had seemed to be responding to commands that the officers were giving to him. He was responsive to those, it seemed like. But he was still in a daze, and when that gets even worse so that he's not responsive at all, that means his brain has reached another significant level of non-functioning, and it's really becoming critical at that time that if you're going to do anything, it needs to be done as soon as possible.
Okay, and you're talking about someone who can't get up on their own.
Correct.
Would be consistent with someone who's lying down in a fetal position.
Correct.
It would be consistent with someone else trying to help that person trying to get up, but they don't have the strength to help themselves up.
That's correct.
You talked about going from maybe being able to respond without words, but if you tell me to go this way, I go this way, and when all of a sudden they can't even do that anymore.
That's correct.
I thought you mentioned three things. So the one was the can't get up, one was not following any commands at all. What else was the other thing that you just mentioned?
Just his lack of interaction or responsiveness, and his moaning that he was experiencing as well, suggesting that he was not very happy with his situation.
Okay. And by the way, I haven't mentioned this much at all, Doctor, but when a person's suffering from pneumonia, before we even get to sepsis, is it a difficult, painful, suffering type of process?
Before you answer.
Don't answer.
Counsel, could you approach, please?
Certainly. Doctor, frankly, I forget my last question, but I want to move to the 10th anyway, the morning of the 10th. So as I understand what you've been telling us is that the morning of the 10th, let's say 6, 7, 8 o'clock, you know that there's a report about the inmate. He's out walking around a bit aimlessly.
Correct.
Okay. And it's your opinion, if I'm understanding you correctly, that at that time he's still suffering from pneumonia.
Correct.
And it's treatable still.
Correct.
It would just be someone get him to the hospital and get him antibiotics and he's going to survive.
Correct.
All right. And now as the hours go by on the 10th, time is becoming more and more important.
That's correct.
All right. And you're telling us that you believe at some point that morning to afternoon he's developing sepsis.
That's correct.
Okay. And again, those things that you mentioned that the jury's heard about, the not being able to get up, the much increased change in responsiveness, and the other items that you mentioned, that's when they're trying to assess the timeline of this deterioration process. Those are the things you're telling them to keep an eye out for as they assess this evidence.
That's correct.
Okay. Even still, at the point where he's I guess maybe at a point when he's in this cell with Officer Jameson, and he can't get up, but he's trying to get up, can he be treated with antibiotics that will address the sepsis and the pneumonia?
Yes, he can.
Okay. And is it in the same fashion that you described to this jury?
Yes.
Same antibiotics that are exquisitely sensitive to treating this type of pneumonia?
Well, it's a little bit different because the situation's a little bit different. When somebody has pneumococcal pneumonia and they become unresponsive, then you have to worry about the infection involving the central nervous system. And if that's the case, then you can't use oral antibiotics in that setting. You have to use intravenous antibiotics because you have to get really high levels of antibiotics in order to penetrate into the central nervous system. So the alarms are going off when he is lying on the floor in fetal position that there's really something serious going on and something needs to be done as soon as possible.
All right. And Doctor, do you believe that sometime thereafter, before he gets to Via Christi, that he develops meningitis?
Yes.
And again, it's this progression that you're talking about that was left untreated.
That's correct.
All right. And could you explain to the jury what the meningitis is? They've already heard a little bit about it. You weren't in here. You were out in the hallway. But just tell them a little bit about what is meningitis from your perspective.
Again, meningitis is when bacteria get into the fluid that is basically the cushion of our brain inside of our skull, because we have fluid in there, and that fluid allows me to jerk my head around and without it giving myself a concussion, and it buffers the brain. When that area gets bacteria into it, the way the body responds to an infection is it causes fluid to go into the area and it causes white cells to go into the area. It's like if you have a pimple and that pimple gets hurt, it's because it's swollen, it's red, it's tender. That's your immune system. The white cells are going in there and the fluid is going in there. As the fluid gets inside the brain, because all of our skulls are hard, it doesn't expand, so the pressure goes up inside the brain. And that pressure and that inflammatory response is what causes damage to the brain. And so the sooner you can stop the infection, the sooner you can stop this inflammatory process, because it's like an explosion has just gone off in the brain, and what you're trying to do is minimize that damage by turning off the inflammation that's occurring inside the brain. When the pressure builds up enough, people die because it eventually causes the brain to sink down and stop the blood supply to the brain and block off all the nerves that are there. And that's the tragic conclusion that can occur when people have bacterial meningitis.
All right. But even as he gets the bacterial meningitis and for some period of time after that, can he still be saved? Can Terry Bruner, in your medical opinion, still be saved with treatment?
Yes.
And is it still relatively simple treatment?
Yes.
Could you tell the jury what it is, what he would need?
What he would need would be intravenous antibiotics. That means antibiotics that's put in through an IV. And he would also need some powerful anti-inflammatory medicines called corticosteroids, like prednisone or Decadron. And what those do, the antibiotics kill the bugs, and the steroids minimize the inflammation, which is causing the swelling to occur, which is what ultimately causes the damage in people with meningitis.
And again, even though he has cirrhosis, as at least to the degree that you've described for the jury, can he still be saved? Can he still be saved with that treatment that you just described, notwithstanding his cirrhosis?
Yes, he definitely can.
Okay. And do you believe, doctor, that because of what occurred on the 10th, that there was a delay, that the defendants participated in a delay or not at all of getting treatment to Terry Bruner in a timely fashion?
Yeah.
Sorry, counsel, I can't hear you.
I apologize. I think he seems to be asking some sort of standard. Maybe I'm missing what it is.
I haven't asked for a standard. I'm sorry, I didn't mean to interrupt.
I thought he was just asking if the delay was a cause of his injury.
Well, maybe I misunderstood the question, because I thought he was asking about delay by these two defendants.
Well, I think he was asking about delay by these two defendants.
I don't think that he ought to be testifying about the conduct of these defendants. It's not within the scope of this report.
Well, these are the only two defendants that we have in the case, so I think you can cover that on cross-examination if you think he doesn't have a sufficient basis for that opinion.
Do you want me to repeat the question?
Please.
No problem. Actually, the judge said it better than I did. Do you believe that the fact that the defendants did not get treatment for Mr. Bruner for the period of time that they were there and could have caused him to deteriorate and worsen over time?
Same objection, Your Honor. I don't know where the good outcomes. I don't think it's a proper subject for this testimony.
Yes, definitely.
Do you think that he deteriorated in every minute that they delayed and didn't get him treatment?
I do.
And do you believe that that ultimately led to his death?
I do.
Because at some point in time during this day and later on into the afternoon and evening, he's not salvageable anymore, is he?
That's correct.
Okay, and you can't tell the jury exactly when that time is, can you?
No.
Okay, because he's not in a medical setting and they're not monitoring him minute to minute or even closely in terms of everything they need to be monitoring.
That's correct.
Okay, but can you tell us beyond a certain time that you're comfortable saying, yeah, I really believe he's survivable? Can you tell us if you have an opinion like that?
I think it was survivable up until he reached Via Christi emergency room.
Okay. And doctor, in terms of, again, the defendants, do you believe that Mr. Bruner was caused to suffer unnecessary pain, suffering, discomfort, whatever symptoms and whatever a person going through that feels inside? Do you think that their delay, their inactivity, their failure to get him help caused him to suffer that by the minute?
This is not a proper subject for expert opinion, Your Honor, and it's well beyond the scope of the report.
Is there anything in the report about this opinion you're asking him? I don't see it right offhand.
The number 3, Your Honor, are some of the things that the patient would go through because of the meningitis.
Well, you can ask him about symptoms of meningitis.
Okay. In terms of this case and Mr. Bruner, do you believe that he was caused to suffer the symptoms of meningitis for a period of time during which the defendants delayed in not getting him treatment?
Yes.
I don't have any more questions. Thank you for your time.
Thank you.
Cross-examination.
Do you have a copy of your report in front of you, Doctor?
No, I do not.
Counsel, do you have a copy of your report that your witness can use? I don't plan on marking it. If you want to just let him borrow it for a moment. Thank you, counsel. See, your specialties are internal medicine and infectious disease, is that correct?
Yes, sir.
Under what circumstances do you consult with a forensics pathologist to treat your patients that have conditions like Mr. Bruner suffered from?
Under what conditions do I consult with a forensic pathologist?
Now, when do you, in order to treat your patients who have the conditions that you described Mr. Bruner as having, when do you consult with a forensics pathologist?
I usually consult with them when I don't understand what's happened with a patient's clinical course, or if I've somehow made a mistake, just to understand better what the clinical course of the condition was and how I could learn from that and do something better the next time.
And this is after the patient has died?
Yes.
Now, have you ever consulted with a forensic pathologist to do your job before the patient died?
No.
You have been involved in the medical legal field, I think you said, in addition to your practice for several years, is that correct?
That's correct.
And you have worked with Mr. Feiger's firm, 20 times or more, I take it?
That's correct.
You authored a report, and knowing how the medical legal world works, you tried to include in your report a summary of the opinions that you were going to testify to so that the parties would know what they are and be prepared to cross-examine them if appropriate. You understood that, didn't you?
Yes.
Did you try to hold back anything in your report?
No.
Or did you try to be accurate with your report?
Yes.
Did you try to be fair with your report?
Yes.
Now, you had indicated that the basis for Mr. Bruner's death was herniation with pneumococcal meningitis and hepatic encephalopathy in connection with your report, didn't you?
Yes.
I didn't hear about the hepatic encephalopathy today. What is that?
Hepatic encephalopathy occurs when people have elevated ammonia levels, and the ammonia affects the triggering of the neurons in the brain. And it can occur in the setting of liver disease, and also certain medications can also cause that to occur.
Now, you indicated, I think today, that the meningitis that onset with Mr. Bruner, in your opinion, didn't happen or onset for the first time until the night of March 10, 2008. Is that right?
I'm sorry.
Well, I think you said he first had meningitis, and maybe I misheard, when he was on his way to Via Christi.
That's correct.
And he was on the way to Via Christi, as you recall, just shortly before 9:30 on March 10, 2008.
That's correct.
So it would have been the night of March 10, 2008 that you're now saying that he first contracted the meningitis.
Oh, I'm sorry. I didn't mean to intend that.
Okay.
When he became non-conversant and unresponsive, when he was still at the medical facility at Sedgwick, any time from there on was when the meningitis began.
So you're thinking it's when he was first taken to the clinic operated by ConMed in the afternoon of March 10 that he first contracted the meningitis?
Well, again, just to be clear, You contract meningitis, which means the infection starts. You have clinical manifestations of meningitis, meaning depressed mental status at some time after that infection begins. And when he was in fetal position on the floor, and Officer Jameson came in and picked him up and put him on his bed, that's when my concern for meningitis would have been.
Okay, so you're thinking now at 2:11, when Officer Jameson went into his cell, that he had meningitis.
That's a possibility.
Well, I'm lost. What's your opinion? Is that you're saying that he likely had meningitis at 2:11 on March 10, 2008?
I'm saying that he likely had a condition that was going to result in his death unless something was done. Knowing the exact onset of meningitis is difficult to ascertain. Certainly, being in fetal position and non-responsive is consistent with having bacterial meningitis at that time.
Okay, and I appreciate that answer, but I don't think it gets to my question. Maybe you don't know. When did he first contract the meningitis? When did he first have it?
I can't tell you exactly when he had the, when he first got it.
So he might have had the meningitis earlier on March 10 of 2008 than 2:11 in the afternoon.
When you say he might have had it,
Yeah.
the infection could have been brewing in his brain, but he could not let anyone know that by the fact that he was unresponsive and lying on the floor.
He could have had it, in your opinion, as soon as, 7:30 or 7 o'clock in the morning on March 10, 2008?
I don't believe so.
So sometime, in your opinion, between the morning and then the afternoon is when he got the meningitis.
Correct.
And I had thought I had heard that he first got the meningitis when he was on the way to Via Christi. Apparently I misunderstood. It's your opinion that he probably had the meningitis before then.
Yes.
Now, we went on a little bit of a circular route there because I was wondering about the hepatic encephalopathy. When did he have the hepatic encephalopathy?
Well, when he arrived at Via Christi, his ammonia level, which is the toxin that is not taken away by the liver, was elevated. So he certainly had it when he was in Via Christi. There was not another ammonia level done to know that he had it prior to that.
Well, isn't it then your position that he had the hepatic encephalopathy back on March 5 when he was out in Staton County?
He could have, yes.
Well, I appreciate that he could have. Is it your opinion that he likely did or didn't?
Again, I can't tell that for sure because we don't have any blood work to tell that. All we know is that he was not eating for a period of time and that he had blood in his stools and he didn't look very good.
Now, your opinion was at one point that he had gastrointestinal bleeding that led to hepatic encephalopathy, resulting in aspiration pneumonia, which later developed in pneumococcal meningitis sometime on 3/9 or 3/10. That was your opinion back in the time of your deposition that we took out in Santa Barbara. Have you changed that opinion?
That's one possibility for what occurred.
And that was what you thought was most likely back at the time of the deposition, right?
That's correct.
And under that sequence, sir, then it would have been earlier than March 10 in the morning that he had the pneumococcal meningitis.
No, people don't survive that long with pneumococcal meningitis. They're not up walking around with pneumococcal meningitis. That's not a clinical possibility.
I see. So when you said in your deposition, let me see if I can get a copy of that for you. Here, let me get a copy. It's at page 70 or 67, counsel.
While they're doing that, you've heard the lawyers talk about depositions, and I should probably say a few words about what depositions are. After a civil lawsuit is filed, there's a period of time which we call discovery. And during discovery, both sides have a chance to use various techniques to find out what the other side's positions will be at trial and what facts they're relying on. One of the techniques is called a deposition. It's somewhat similar to a court proceeding in that there's a witness who's under oath, the lawyers for both sides are present, there's a court reporter there, and the lawyers get to ask questions of the witness very much like we're doing here, direct and cross-examination. The main difference is that there's no judge there, but after the deposition is over, then the court reporter writes down all the questions and answers. It's sent to the witness, who has 30 days then to review the deposition transcript, and then the witness signs off again that this is an accurate transcript. Depositions can be used to impeach a witness's testimony at trial, or if the witness is not available for some reason, the deposition testimony can be used instead of live evidence. So when the parties talk about the depositions and flip through these binders, that's what they're referring to.
Okay, thank you.
Go ahead.
It's the bottom part of the A.
Where you said in your deposition that I believe he had gastrointestinal bleeding sometime before March 5th, that led to him develop hepatic encephalopathy. He had some nausea and vomiting that occurred that caused him to have aspiration pneumonia, and then he subsequently developed pneumonia or pneumococcal meningitis sometime on the 9th or 10th of March, and succumbed to the pneumococcal meningitis because of a lack of appropriate therapy being initiated. Where you say on the 9th and 10th, apparently you didn't mean the 9th, because that wouldn't have been clinically possible.
That's correct.
So what you're really saying is it's on the 10th, and you think it might have been as early as the afternoon of the 10th. That's what your testimony is now.
Correct.
Now, at the time, however, you were asked by counsel, and is all that your opinion within a reasonable degree of medical certainty? And your answer was yes. So at the time, your thought was that it could have been on the 9th.
That's correct.
Now, Mr. Bruner had a number of core comorbidities that led to his death. Is that right?
That's correct.
He had the pneumococcal bacterial meningitis.
That's correct.
Pneumococcal meningitis can be a fatal disease even if it's treated. Is that right?
That's correct.
So if he had it on the 9th, even it's not as simple as just give him antibiotics and seeing how it works out, is it?
If he was given antibiotics on the 9th, it would have been as simple as that, yes.
If he had the pneumococcal meningitis, as you said in your deposition on the 9th, it wouldn't have been that simple, just to give him the antibiotics and assume that he would survive.
The antibiotics and the anti-inflammatory medicines.
You agree that Mr. Bruner died of acute meningitis, don't you?
Yes.
Acute, meaning meningitis with meningitis, means within 24 to 48 hours onset of the meningitis to death if not treated, right?
Correct.
Highly acute onset means death if not treated within 3 to 6 hours, right?
Right.
You agree that the most likely cause, or the most likely organism here that caused the meningitis was the streptococcal pneumonia, right?
Correct.
And you agree that the cultures, the meningeal, is that the way you pronounce it?
The meningeal cultures.
The meningeal, which are the cultures that lead to the meningitis, right?
Right. Culture of the spinal fluid.
They grew out of a Staph aureus which may, I can't even read my writing here. Well, let me see if I can put it here in language that it makes sense to me. And that is that the meningitis cultures grew out of the staph that he developed, right? The staph infection.
Those were post-mortem cultures. And the cultures that were taken as a result of his ventriculostomy, when they put the tube into the center of his brain to sample that fluid, grew Streptococcus pneumoniae. The cultures you're referring to are post-mortem cultures, which are notoriously unreliable.
Okay, and that's helpful to understand. Mr. Bruner had a form of MRSA on the body, didn't he?
He did.
What is MRSA?
It stands for methicillin-resistant Staph aureus.
And by nature, it can be resistant to antibiotic treatment, can't it?
It can be, but he did receive antibiotics that were active against MRSA when he was first admitted to Via Christi in the emergency room.
But it still, notwithstanding, can be resistant to that antibiotic treatment, can't it?
No.
Well, maybe I misunderstood. If we look at page 47 of your deposition, and maybe I did misunderstand, because at page 47 of your deposition, the question is, can MRSA be resistant to antibiotic treatment? And you said it can be resistant to some antibiotic treatment, but not all. And apparently he got the right type. Is that what you're meaning to say here?
That's correct.
Okay. That clarifies that. Now, in addition to the pneumococcal bacterial meningitis he died from, you believe he had hepatic encephalopathy. We've talked about that.
Correct.
And this hepatic encephalopathy does not usually cause brain herniation. Is that right?
That's correct.
Now, however, on the other hand, Mr. Bruner had sepsis. You testified to that. Is that correct?
That's correct.
Now, hepatic encephalopathy, untreated, can wax and wane, can't it? That is, depending on what's causing it, you may show signs of it, you may not.
That's correct.
And the encephalopathy we're talking about, as it would look to you, well, not to you, but to me, as a layperson, would kind of look like someone who has confusion, right?
That's one manifestation, yes.
But even if you've got hepatic encephalopathy, even if it waxes and wanes, if someone is bleeding in his gastrointestinal area, his gut, basically, that is not a condition that's going to improve on its own, is it?
Sure it is.
Oh, it is. Okay. So Mr. Bruner could have had some confusion that was attributed to the hepatic encephalopathy that waxes and wanes and maybe could have improved by its own.
That's correct.
It didn't happen, but it could have.
That's correct.
Yeah. Now, an adult male with acute bacterial meningitis, let's talk about that for a moment. That person has a likelihood of death of about 21 to 30%. Isn't that reasonable?
That's reasonable if they only receive antibiotics.
And in this instance, it was your opinion that if Mr. Bruner had been treated for these conditions earlier, given his underlying medical conditions, some of these comorbidities we've talked about, his prognosis was still poor, right?
No.
Well, maybe I misunderstood again. If we turn to 37 of your deposition. And maybe you can just explain this to me. At page 37 of your deposition at line 12, the question is it correct with these comorbidities and with the situation of end-stage liver disease, he, that is Mr. Bruner, had a poor prognosis? Your answer was for a transplant or just a poor prognosis in general? And the question was poor prognosis in general, and the answer was yes. Is that the distinction you're drawing here? If he got his transplant, his prognosis was good?
My objection is that is completely out of context unless you read the page before where they're talking about a different condition entirely, where they talk about the lactulose being used to detoxify the ammonia out of the blood system. That's what he was talking about. He wasn't talking about the meningitis on the page that Mr. Chalmers is discussing.
I think that if that's the case, I think the witness can clarify that for me, Your Honor.
Well, if he'd be permitted, instead of just being stuck with the question and answer that you picked, to read the page before, I'd appreciate it.
I think he can answer the question and clarify what it is. If it's as counsel has told him his testimony should be, then that's fine. If
I think he picked up, he should probably look at the page before.
All right,
So-
go ahead. He's talking about page 36. If you want to look at that real quickly, that's fine. Okay. And what I'm struggling with is where, at page 37, where you're talking about with the comorbidities that Mr. Bruner had and the situation of end-stage liver disease. But let's depart from that for a second. He had end-stage liver disease, didn't he?
Yes.
What is end-stage liver disease?
It's when the liver doesn't work like it normally does, and there is a continuum of when it doesn't work a little bit and to where it doesn't work a lot. And he is on that spectrum. He has still got relatively good liver function, as evidenced by the MELD score that I talked about earlier.
End-stage liver disease causes death, right?
It does.
Bleeding in the stool can arise from end-stage liver disease, right?
That's correct.
Now, going back to the question, with these comorbidities, that is the end-stage liver disease and the 11th-stage liver disease, he had a poor prognosis. And I'm trying to get at where you're going from. Are you saying that given his end-stage liver disease and the comorbidities that we've talked about, that is the various reasons for which he died, that he had anything other than a poor prognosis?
Well, again, the question before, I thought we were talking about liver transplant, and his poor prognosis was for living a normal lifespan like you or me. And certainly he would have a poor prognosis for that because he was still drinking and was not a candidate for a liver transplant. I didn't believe that this question had anything to do with his prognosis in surviving from his bacterial meningitis.
Okay, well, that's what I'm trying to get a handle on, is whether or not Mr. Bruner, not someone distinct from Mr. Bruner with the meningitis, what his prognosis was. And I think what you're saying is because of the end-stage liver disease he had, his prognosis was good, even if he'd gotten all the treatments that you talked about, or his prognosis was poor, rather.
His ultimate prognosis 10 to 12 years down the line was poor, but his prognosis for his surviving the meningitis was not significantly different from someone who didn't have liver disease.
You're suggesting that he had a expected life expectancy or a lifespan with his liver disease if he doesn't get a transplant of 10 to 12 years?
I don't know that.
I mean, there is data and there is information based on the scoring that you just talked about that would suggest that he had a much shorter life expectancy, isn't there?
Again, I refer people for liver transplantation. I don't do liver transplantations.
So you would rely on someone who does the liver transplants and treats that condition to give the opinion as to what his life expectancy was and on how well he would respond to treatment given his end-stage liver disease, wouldn't you?
Respond to treatment for his end-stage liver disease or for his bacterial meningitis?
Bacterial meningitis.
No, I can handle his prognosis with regard to his bacterial meningitis, since that's what I do a lot.
The theory that you had at one point about the aspirational or aspiration pneumonia, and that's where he kind of vomits and swallows some of his own vomit, and that's the source of the pneumonia. Is that still your theory?
That's one possible way of getting pneumococcal pneumonia. The bacteria have to get from the posterior pharynx down into the lungs some way or another, and certainly vomiting is one way to do that. And since he had vomiting, aspiration can cause the bugs to get down into the lungs, and that's how the pneumococcus got there and subsequently spread.
Well, you're thinking that the bug here, that is the material here that caused the meningitis, is something that was in his vomit?
Well, when people vomit, the usual sequence of events is that it comes up into your posterior pharynx, and that's where these bacteria live, the pneumococcus and all the bacteria that are present in your mouth. Then when it goes down into the lungs, those bacteria are carried down there. So that's one of the ways that people get pneumococcal pneumonia is from aspiration, particularly alcoholics.
Can't we look and see what bug he had to see whether or not that was how he contracted the meningitis in this instance?
Well, we know that the bug that he had...
we have from the autopsy what he had?
I guess I'm not quite understanding, because the bug that caused his meningitis was Streptococcus pneumoniae.
Well, the bacterial meningitis, and I'm being probably callous, and I shouldn't be with the word bacterial. That bacterial I've been referring to as the bug. What bug was it that he had?
Streptococcus pneumoniae, which we call the pneumococcus, and therefore we call it pneumococcal meningitis.
And you think that you can get that bug from the aspiration or from his vomit, more accurately?
That's correct.
Confusion can be an indicator of hepatic encephalopathy, right?
Correct.
Now, to a non-physician's observations, there's a wide range of interpretation as to what constitutes confusion, though, isn't there?
Some people are very confused about that.
That'd be me. And there are an array of things that can cause confusion.
That's correct. There are lots of things.
Personality can cause, a disorder can cause confusion.
Can.
Certain medications can cause confusion or the appearance of confusion.
Correct.
Confusion might be explained by dehydration.
Maybe.
Well, there's no maybe about it. You can have dehydration and get to the stage that you're confused, can't you?
If the dehydration is severe enough to cause the BUN and creatinine to be elevated, which was not the case in this situation.
Yeah. Now, where you say that Bruner had symptoms consistent with meningitis, that was after sometime around 2 or 3 p.m. on March 10, right?
I would say 2 o'clock was when Officer Jameson came in and picked him up off the floor from fetal position, and he was confused, although I believe Officer Jameson suggested he still had that dazed look in his eye, like he had had earlier in the day when he had had an interaction with him.
Well, what I'm trying to get a handle on is that when you are saying that he had symptoms that are characteristic of meningitis, and I think you provided some testimony of this earlier, that was after either 2 or 3 p.m. when Officer Jameson went in and saw him, right?
Well, the symptoms he had when he was in fetal position and confused, that is also consistent with meningitis as well. When he got into the hospital and he had a low blood pressure and he couldn't breathe and his cranial nerves were more dysfunctional, there was no question about that, and that's how the emergency room responded.
I don't know that I don't know that we're saying anything different. I'm just trying to make sure we're communicating here.
Sorry, I guess I didn't understand it.
Well, mine's a bad question, and that is those things that you described. That is laying in a fetal position, that is not being responsive, having to be picked up, put on the bunk, and the other things. Those were all after or at the time that Mr. Jameson saw him at about 2:11 on March 10. And what I'm trying to get an understanding of is all those either were at that time or after.
That's correct.
Because before then, that is before March 10, at that time frame, we really don't know anything about what his symptoms look like, do we?
Well, no, I would disagree. We know that he was confused, or dazed, I think is the term that was used. He was wandering about aimlessly. He was doing things that most normal people don't do. So I think those were clearly symptoms that his brain was not working normally.
Okay. Now, I just want to be clear on here. Are we now talking about symptoms his brain is not working properly because of meningitis?
No, because of his underlying pneumonia and his hepatic encephalopathy.
Okay. So, but the meningitis, in terms of that issue, before 2 or 3, we really can't say what symptoms that was causing in him, if any.
That's correct.
Now, hepatic encephalopathy symptoms may be slowly and gradually worsened, or they may be suddenly severe from the start. Isn't that true?
That's true.
The symptoms of hepatic encephalopathy may be mild at first. Isn't that true?
That's true.
And when we're talking about hepatic encephalopathy, again, we're talking essentially about the confusion from the swelling caused by issues initiated by the liver, right?
Well, it's initiated by the toxins that are present, yeah.
Yeah. So with Mr. Bruner, it's initiated from the fact that he's got the end-stage liver disease that may be producing the toxins that create the confusion, right?
Well, it's not exactly right, but because the toxins, we all have those toxins, but our liver takes those toxins out of our body. And those toxins are produced more if we're sick, if we have an infection. That's one of the causes of hepatic encephalopathy is actually infection, not just gastrointestinal bleeding, which he really had no significant evidence of.
And I appreciate that, because really what the liver does kind of act as, a cleansing liver.
A filter.
Yeah. So if the liver isn't working properly, that makes you more susceptible to, your immunity is lowered. And if you don't have a liver, then you don't have no immunity, you die.
You don't have what?
If you don't have a liver, you lose that filtering ability and you die.
That's one way of looking at it, yes.
The first signs of meningitis, stepping aside from the encephalopathy for a moment, can be quite general and may consist of a headache, a high temperature, tiredness, or irritability, right?
Correct.
It's possible that both the symptoms that can it's possible as to both the hepatic encephalopathy as well as the meningitis, both those conditions, that they can first present in the same fashion as would the common cold or flu. Isn't that right?
The common cold or flu does not usually present as encephalopathy. You can certainly have fatigue, but it doesn't go on for 5 to 7 days.
Your deposition at page 48, if we look at that real quick, line 19. It reads, "And is it true as to both meningitis as well as," and I misspoke the word there, but I think I meant to say hepatic encephalopathy, that the symptoms can first present in the same fashion as would a common cold or the flu? And your answer was, it's possible. Is that correct?
I said it's possible, but in clinical medicine, many things are possible, but that doesn't mean that's a probable way that they present.
Okay, and I appreciate that. You didn't say that in clinical medicine it was improbable. You said it was possible, didn't you?
Yes.
Now, you, sir, when you authored your report and then when you provided your testimony in the deposition as the judge described it, were asked if you had formed any opinions that Mr. Bruner's symptoms were different than or in addition to those that were reported by the detention staff on their observations on March 9 and March 10. And your answer was that you had not formed that opinion. Is that true?
That's what I said. It's what I believe to be
Well,
true
if
at
we
that time.
look at page 48 of your deposition, is where that's discussed, if we need to look at it. But the point is that when you authored your report and when you provided testimony, you were saying, hey, look, I'm not going to express any opinion that the symptoms as were described by the deputies were any different than what they described. And you're not making that sort of assertion here today, are you?
Well, the deputies didn't describe nausea, vomiting, and coughing, which I've come to learn is some of the symptoms that he was manifesting.
Oh, you've come to learn there's some testimony from inmates to that effect, is that right?
That's correct.
For instance, Mr. Ewells testified and he'd been found to be incompetent to even stand trial to his observations. Is that you understood that?
That's correct.
And so the question I have is not whether or not there's someone who said something different than what the deputies said. The point is that when you authored your report based on the medical records that you reviewed, which would have been the objective way to evaluate what the symptoms were, at that time, reviewing those records, you concluded, I don't have enough information to dispute what the deputies described as being accurate in their observations of Mr. Bruner. Isn't that true?
That's correct.
In your report, and on the last page under Opinion 6, at that time you were authoring an opinion as to whether Mr. Bruner would have likely survived if he had been seen, evaluated, and treated. And the opinion that you expressed was that if he had been seen, evaluated, and treated by medical personnel at any time between March 5 and the morning of March 10, he likely would have survived. That was the opinion you expressed then. Is that right?
Correct.
And seen means, I guess, seen by a medical person in that opinion, correct?
Correct.
Evaluated means, again, evaluated by a medical person. Is that right?
That's correct.
And treated means treated by a medical person, and in particular given antibiotics, as you've described, right?
Right.
So it was the morning of March 10 that he had to be seen, evaluated, and treated for him to have likely survived at the time you authored the report and then provided your deposition testimony. Is that correct?
That was by medical personnel that was at Sedgwick.
That's
Because
fine.
at that time, he only had pneumonia and hepatic encephalopathy, which could be treated with pills.
So if he had been seen by medical staff, the clinic, at the morning of March 10, that he would have likely survived was the opinion you were expressing.
I'm not... That presumes that the medical personnel would have made appropriate decisions, and I don't have any evidence to suggest that they would have made appropriate decisions based on their subsequent decisions.
Well, then what we really are saying is not that he's seen by ConMed, but rather that he receives antibiotics and he needed to have the antibiotics by the morning of March 10 to be able to survive. That was your opinion.
No, he needed to have the antibiotics by then to have the pneumonia treated so that he wouldn't have developed the meningitis.
Well, you had indicated in your report that he had hepatic encephalopathy by March 10.
That's correct, and that can be treated with oral medicines
And
as
you
well.
had indicated in your report or in your deposition testimony that he had meningitis by either March 9 or March 10. Remember, we talked about that?
No, objection. That's not in his report, Your Honor.
No, in his deposition, counsel.
He didn't have clinical symptoms of meningitis on the 9th or the morning of the 10th.
So were you saying in your report that he had been seen, evaluated, and treated by medical personnel anytime between March 5 and the morning of March 10, he likely would have survived? What you were trying to communicate was if he had been seen before he got the meningitis, he likely would have survived.
Correct.
Once he had the meningitis, your opinion is, well, you don't express an opinion here, do you? So you had never authored an opinion as to what he was going to, what his likelihood of survivability was with the meningitis before, after March 10 in your report, do you?
But once he developed meningitis, then he needed to be seen by physicians at an emergency room who had appropriate medical facilities to take care of him, which would not have been at the medical clinic.
And it was your opinion that the delay of diagnosis and treatment of the bacterial meningitis from 3 to 6 hours is associated with an increase in adverse outcomes such as neurological deficit or death, correct?
Correct.
I don't have any other questions, thanks.
Thank you.
Thank you, Your Honor. Doctor, there is a report that the jury has heard, and we've been over a number of times, that Mr. Bruner was walking around 8 o'clock in the morning on March 10th. You're aware of that report?
Yes.
Okay. Would you tell the jury why that means that he could not have had the meningitis at that point in time?
Because when people have meningitis and the swelling is occurring in the brain, you don't have the wherewithal to get up and walk around and to move around and interact appropriately. That's a critical illness where people are usually in the intensive care unit, oftentimes on a ventilator like he was.
All right. And is that one of the various reasons why you believe he didn't get to the end stage, the meningitis stage, until sometime on the 10th?
That's correct.
All right. And in terms of these symptoms, doctor, you did not know at the time that your report was made, which is the time when all you had were corrections officer statements, right?
Correct.
And you didn't know that not only different people, but inmates, and even some of the witnesses have come in and added more to their statements in describing what Mr. Bruner was like. He's now seen as someone who's coughing all the time. He's vomiting. He's wet with sweat all the time. He's lethargic. He's weak. He has difficulty moving. He has difficulty walking, getting up, getting down. Would you agree with me that these are signs and symptoms of someone going through this process?
Yes.
Is that what you're telling the jury you believe occurred to this man?
Yes, most definitely.
By the time of the 10th, when the two defendants are with him, they're the guards who are most responsible for taking care of him, does he look like a very, very sick man, or does he look like someone who's got the common cold?
No, he doesn't look like he's got the common cold.
Does he look like he's got the common flu, or does he look like he's near death?
He would have to look like he's near death because he hasn't had anything to eat. He's been fighting this infection. He's got hepatic encephalopathy. People always look horrible in that particular situation.
And you've been asked a number of questions about hepatic encephalopathy. And the reason we didn't discuss it, it didn't cause his death, did it?
No.
If it existed, it coexisted, but didn't have an impact on bringing about his death, did it?
No.
It was just another reason why the defendant should have noticed how strangely he was acting and how sick he was.
That's absolutely correct.
You were asked questions about whether or not, once you contract the meningitis, do you have a 20 to 30% mortality rate? And your answer was yes, if you're only treated with antibiotics. Do you recall that?
Yes, I do.
Because if you treat with antibiotics and steroids, that rate goes down, doesn't it, Doctor?
It cuts it by about 50%, so the mortality is about 15% if you treat with both steroids and antibiotics.
Which is what you told the jury that he needed after he got the meningitis.
That's correct.
And do you still believe, doctor, that if he would have got treated with those medications after this got to the point where he had meningitis, that he still would have lived more likely than not?
Yes.
Is that what you're telling the ladies and gentlemen of this jury?
Yes, definitely.
You were asked questions about whether or not end-stage liver disease causes death. It didn't here, did it?
No,
He was a long way from that, wasn't he?
that's correct.
And that's evidenced by what, doctor?
Well, the reason people die of end-stage liver disease, it's usually from uncontrolled bleeding. But at the autopsy, he had no bleeding in his gastrointestinal tract. When he was admitted to Via Christi Hospital, his hemoglobin, which is his red blood count, was normal, which meant he had not lost significant amounts of blood at all. So there really wasn't any indication that complications from his liver disease were contributing to his death at all.
Thank you, doctor. No more questions.
Recross.
The reason that people generally don't die of the end-stage liver disease is because that makes them susceptible to infection, and they die of an infection, right?
That's one of the reasons they die, yes.
And that's what happened here.
He did die of infection.
He
That's
was
correct.
he was somebody who, because of his end-stage liver disease, was going to get some sort of infection, wasn't he? And he
Not
was,
necessarily.
And he was likely to die.
He's more likely than someone who doesn't have end-stage liver disease, yes.
You ever heard the phrase walking pneumonia?
Yes, I have.
What is that?
Walking pneumonia is
Your Honor,
when...
Your Honor, I object. This is beyond the scope of my redirect.
I think so.
Well, I think I can tie it up. You said he had the hepatic encephalopathy, or counsel talked to you about that, and you said the reason you didn't mention it, he didn't die of the hepatic encephalopathy, but that you indicated that that would have been something that would have made it clear that he probably needed help on March 10? Is that what you said?
I'm sorry, I don't understand.
No, maybe I didn't either. You had testified, you answered a lot of questions yes to plaintiff's counsel, or to Mr. Giroux, and one of them was that this individual had hepatic encephalopathy, but it didn't kill him, right?
Correct.
But the fact that he had the hepatic encephalopathy, in your opinion, produced symptoms that showed that he was a sick guy that needed help, right?
Correct.
And what I'm trying to get at is those symptoms are typically the type of symptoms that you'd see with someone with walking pneumonia.
Same objection, Your Honor.
Well, walking pneumonia is essentially when people come into a physician's office, they're coughing, and they look well enough to be discharged home. They get sent for a chest x-ray, and the radiologist calls in and says, oh, your patient has got pneumonia. That's because people are well enough with walking pneumonia, and that's usually caused by mycoplasma, which is an infection that people walk around continuously going, and you can't not be around them and not know that they're coughing with that non-productive kind of cough. So he had pneumonia and he was walking, but that's not what we usually believe in medical parlance to be walking pneumonia.
And when you've described the pneumonia that he had, or when you're talking about the symptoms that he had in terms of getting sicker and sicker with the pneumonia, those are the sort of symptoms we look at that normally would be associated with the flu, aren't we?
But people don't have the flu for that long a period of time. when people get the flu, it's sudden onset of headache, severe muscle aches and pains, and fever. And he did not have those symptoms.
And nobody's quarreling with that, but on March 10, to these two deputies, when they first saw them, you understand they had no history with him before. Or did you understand that?
I understand.
So when they saw him on March 10, what they would have seen would have been somebody who had symptoms of pneumonia.
Well, again, we agreed that the deputies did not know that he was coughing. I thought we just agreed that. So
Okay.
why would they think he had pneumonia if he wasn't coughing?
So he had symptoms of confusion.
Right, confusion, and that's not a usual symptom of the flu.
And we've acknowledged, or I think agreed, that there are lots of different sources and explanations for confusion.
That's true.
Now, by that afternoon, now he's not moving around, but it is at that point, I think you're indicating he's contracted the meningitis, right?
That's when I would be concerned about that, yes.
So I'm trying to get the understanding of the progression here. If he is responding to commands and he's up walking around and he's not coughing in the morning of March 10, and yet if he's found on the floor laying in a fetal position, unresponsive, the afternoon of March 10, then what we have is the progression during that time frame that you talked about, where he gets sicker and sicker, right?
That's correct.
I don't have anything else, thanks.
No more questions, Your Honor.
Can this witness be excused?
Yes, Your Honor.
Yes.
Okay. Thank you, doctor.